Dr. Abhishek, please mute yourself till I introduce you. Yeah. Can I start now, Rahul? We are live.
Yes, ma'am. We are already live.
Okay. Good afternoon, friends. Wish you all a very happy, peaceful, and prosperous Diwali. So, after the Diwali celebrations, FFPI is back again with the last and fourth session on rheumatology and clinical immunology by Dr. Abhishek Patil. So before we move on to the actual session today, I have one or two announcements to make. So keep ready, take a paper, note down. On behalf of Pragnesh Shah, the president, and Dr. Pragnesh Vacharajani, the honorary secretary, I welcome you all to today's session. And at the same time, I welcome you all to join in large numbers for our certificate course. So the FFPAI, in association with AFPI, Academy of Family Physicians of India, under the leadership of Dr. Mohan Kubendra, we are going to come out with a certificate course in lifestyle disease management. Now, this course will be over a 6-month period. It will be virtual or on an online mode. The topics covered will be mainly diabetes, hypertension, and cardiac problems. We will be having a lot of national faculties to talk to us on these topics, very renowned speakers. Certificate will be awarded at the end of the program. Registration is free, totally free, but registration is mandatory. And you have live option. We will be having it live. And at the same time, you have the option of self-paced learning at a later date. But remember, the certificate will be awarded only when you complete all the criteria. Your timing and your your learning will be monitored back end, and only when you complete that, the certificate will be awarded to you for all the sessions. It will be over a period of 6 months. And over now, I have the pleasurable or honorable duty. It's my pleasure to introduce Dr. Abhishek Patil today. Before that, I apologize for starting a little late. Our speaker was a little busy post Diwali. Yeah. So he has done his MD from KIMS Hubli, MBBS from KIMS Hubli, MD Medicine from Delhi, GTB Hospital, and Rheumatology DNB, Indraprastha Hospital, Apollo Hospital, Delhi. He is the president and gold medal winner for rheumatology in NBE 2015. He has had multiple gold medals during his MBBS studies, and DNB rheumatology. Is a DNB rheumatology teacher also at Manipal Hospital. He has many textbook chapters, publications in his credit. He is very interested in reproductive immunology and spondyloarthritis. Now, today he is going to speak on fibromyalgia, and though we may be a little late, still, as speakers, you all can, viewers, you can all post your questions in the chat box, even if it is not today's chapter, because today is the last session of Dr. Abhishek Patil. Thank you, Dr. Abhishek Patil, for accepting our invitation. Over to Dr. Abhishek.
Thank you, ma'am, and thanks FFPI for providing this opportunity. And sorry for being late, and not due to Diwali for sure. It was some ward duties that had come up in the last moment. That's why I had to rush back. We'll go back to my screen. I've started sharing my screen. So I hope screen is visible, ma'am.
Yes, sir, it's visible.
Okay. So we'll begin with something called fibromyalgia, which is actually nobody's child. I mean, or everybody has some inputs probably to give it to. But this is not a disease that is core rheumatology, but it's often what we see as differential for many rheumatic autoimmune disorders. But however, I'm convinced that more and more as I managing these patients, that it requires far more effort to manage a patient with fibromyalgia than that of, say, rheumatoid arthritis. This is something which I have realized now over a period of time. Just because of the pathogenesis that is involved in fibromyalgia, it's so hard to understand and equally important to, treat. It's not an inflammatory disease where you keep bombarding with one after the other drugs. It requires a lot of your patients understanding the prominent pathophysiologic mechanism that is operating in a patient, differentiating from each other, and above all, requires a lot of your time. That is something which I'm really hard pressed for, but something which I need to give if I'm managing a patient of fibromyalgia. So we'll go through definitions. I'm not going to bore with too many textbook definitions, but just the way it has evolved, the way that understanding of fibromyalgia is evolved, we can easily get a glance of that when we see the 1990 and 21 criteria, 2010 criteria. So when you look at rheumatoid arthritis criteria of 1984 and 2010 also, you get an idea how the diagnosis of rheumatoid arthritis has evolved. And same way, when you look at the definitions of fibromyalgia, you will understand how much more that disease carries as opposed to 1990. And pathophysiology, how I typically, how to diagnose, it's not a typical rheumatoid SLE where I can say palpate this joint, carry out a dsDNA, but I can only tell what I do in my practice and what are the important tests or how minimalistic we should be in test, and finally align on management. So a lot of it is individual bias, but that is how, everybody has their own way of managing fibromyalgia. I can only talk about what I generally do. So who are these people with fibromyalgia? As you all, sure, even as family physicians, you will run into a large number of these patients. Probably they will seek your help much more than going to any specialty, because the patients, like specialists, are also confused. They are also confused whether it's a joint problem, whether it's a nerve problem. When a patient develops a stroke, they will go to a neurologist. When a patient develops pain, swelling in a single joint or multiple joints, they will themselves see a rheumatologist or an orthopedician. But when they have fibromyalgia, probably the first care of contact will be the primary physician. And that is why I think you, as family physicians, will come across a large number of these as opposed to, say, SLE or ankle vasculitis. These are the patients who have pains all over the body. So that the important characteristic I want to read about fibromyalgia is pain all over. So this is an important message I want to carry all over. Generally a widespread pain. If you have pain only in back one side or on elbow region, then generally we should not label that as fibromyalgia. It is generally a pain which is present all over the body. They have been told by multiple specialists, probably wrongly, that it is in your head. There is nothing I can find. There's nothing we can't find. That doesn't necessarily mean that it's all in patient's head. Not all of these patients are depressed individuals who have failures. On the contrary, they may be very high achievers in their own life or field. And they are labeled various terms: dyspepsia, migraine, TMJ syndrome, frozen shoulder, IBS, vulvodynia, prostatitis. So it is basically like a blind man looking at an elephant. So when they look at elephant, one looking at its trunk may call it as a snake, one looking at its legs may call it as a wall, and various other things. So just like that, depending upon when a medical practitioner comes across a patient fibromyalgia, and based on what specialty he specializes in, he might call them as by different names. And I'm sure we have all of us had patients with fibromyalgia who have undergone appendicectomy or even a coronary angiography very often. So that's how this disease manifests. It manifests all over. So in 1990 criteria, ACR criteria, it said that anybody who has 11 out of 18 tender points are labeled as fibromyalgia. So basically what they said that you palpate about 5 regions bilaterally, anteriorly and posteriorly another 4 regions at various muscles or the muscles insertion, say the second sternoclavicular joints or sternocleidomastoid, lower border, or lateral epicondyle, greater trochanter on the back, upper outer buttock, on the mid border of the trapezius or supraspinatus, or insertion of the suboccipitus. So you identify these 18 tender joint points, and if you have 11 or more of these tender points, then you call them as fibromyalgia. This was the definition. Now, what that led to is you found a homogeneous group of patients who are basically mainly females who were depressed, and basically you classified a lot of patients with depression, primary major depression, as fibromyalgia, and that is not correct. As of now, we understand now fibromyalgia is not equal to depression. So they most of these develop multiple pain syndrome over lifetime. So they just see, if you go to a depressed person, the fatigue is the main symptom. Fatigue, pain is not the main symptoms. Whereas fibromyalgia, the main central characteristic is pain. Everything else revolves around this. So they develop multiple pain syndrome, pain around the jaws, heart, or around the vaginal area, abdominal area, all over the body. It has some genetic predisposition. There are a number of genetic polymorphisms, like most autoimmune diseases that I deal with. Even fibromyalgia has many genetic predisposition. First degree relatives have about 8.5 times more likely to find fibromyalgia. So it's not at all uncommon in my practice that I find a mother and a daughter with fibromyalgia. This is a very common scenario, a father, a daughter and son, or others having fibromyalgia. It has a female sex predilection. It is different from depression and anxiety. This is a very important distinction that I try to make. That I make sure that they do not have suicidal ideation, depression, or main features of anxiety. These are something where your fibromyalgia line of management does not work. And another important difference, when ACR classified it originally in 1990, presence of any other diseases like rheumatoid, Sjogren's, SLE, all these kinds of pain syndromes, you had an exclusion criteria. But now we know that many of our patients, for example, rheumatoid arthritis, we use a term called non-inflammatory rheumatoid arthritis. I spoke about it briefly, where patients with rheumatoid, despite, according to a clinician, they're all under control. They do not have any swollen joints, inflammatory markers are normal, and still they suffer from pain, and many of them may be having this central sensitization or fibromyalgia. So fibromyalgia can very well coexist with many chronic autoimmune conditions such as rheumatoid arthritis or ankylosing spondylitis. In fact, many reports quote a figure of approximately 50% of patients with this chronic autoimmune disorders having fibromyalgia. And it has overlap with various regional pain syndromes. It can start from migraine, headache, temporomandibular pain, low back, irritable bowel, restless leg, non-cardiac chest pain, multiple allergic symptoms, ENT symptoms, cognitive symptoms, and vulvodynia or urinary issues. They are very common. Dyspareunia, very common, particularly in female patients. Now, after this, we all scientists, wise men, thought that it's not appropriate to classify fibromyalgia only by looking at some tender points and calling someone with 11 out of 18 of this tender point as fibromyalgia. It's a disease which deserves its much more a definition which will be able to rightly classify these patients and differentiate them from other chronic conditions such as chronic fatigue syndrome. So when I'm trying to diagnose fibromyalgia, these are my differentials. So I need to differentiate them from chronic fatigue syndrome. I need to differentiate from major depression or other such psychosomatic disorders where treatment differences would exist between these. So basically, these are the patients have widespread. So first thing that ACR thought that we should introduce is looking at whether the patient has widespread pain. So they classified basically into a jaw area that you can see in the picture here, right jaw, left jaw, neck classified as single area, and then they classified as arm, upper arm, lower arm. Then they had leg, upper leg, lower leg, chest, abdomen in the front. And on the back, they again had upper back, lower back. And these are the, 19 areas they classified. And then they tried to, I'm sorry, and then there is a shoulder girder also, shoulder and hip girdle. So these are the 19 areas they found. And they demonstrated how much pain, whether the patient has pain. Now, ACR definition involved, identify code kg per centimeter square of pressure. So all this is very difficult to do in routine practice. What current definition of fibromyalgia is, if the patient has pain, even you need not elicit tenderness, even if the patient has pain in the jaw area, neck area, shoulder area, upper arm, lower arm, chest, abdomen, upper back, lower back, hip region, and upper arm, upper leg, and lower leg. Then you have these 19 areas, and you see how many areas the patient has pain or tenderness. And then they also given score here, let us say 11 out of 19, 5 widespread pain index. Then they looked at something called symptom severity score. So there they had 3 questionnaires: fatigue, waking underfreshed, and cognitive dysfunctions. You ask the patient, over the last few weeks, how much of fatigue that you have. Can you score it on 0 to 3 basis? 0 is no problem, 1 is slight problem, moderate problem is 2, and 3 severe problem. And after looking at this, how many of the patient has in the last 6 months also you need to look. Pain or cramps in abdomen, depression, headache. Each of them scored 1 for yes or no. So with this, you get a maximum score of 9 out here, 3 into 3, 9. Fatigue, waking up underfreshed, or cognitive decline. So this is something which is very common. So any patient you ask in fibromyalgia, do you wake up fresh? They will say never. First thing I get up in the morning, I feel fatigued, mentally fatigued, because it's not that they're lying. It's because their sympathetic system is in overdrive. So there is no proper REM sleep in them. So that is the reason they have this sleep disturbance, and that's the reason because of their flight-fight response, which is active throughout the night, they wake up underfreshed. They have fatigue, chronic fatigue in doing anything, and then cognitive dysfunction. So that I'm not able to remember so many things. So how severe you ask, and based on that, you give a score for each of them, and a maximum of 3 for each. So that makes it 9 plus 3 simple yes no answers on abdominal pain, depression, and headache. And if you get a score of 5 or more out of the symptom severity score, and widespread pain index of 7 or more, so you call it as fibromyalgia. So that's why it indicates, it's just not sufficient to call someone as fibromyalgia only if you have widespread pain, but also symptom severity score also matters. So at least 3 symptom, at least 5 symptom severity score should be there. So it is not just about pain, but fatigue, waking up underpressed, and cognitive dysfunction, along with pain, abdomen, headache, and depression. So why we have so much symptoms? We have looked at the pain. We had a look at. We all thought it's only pain. Fibromyalgia, definitely pain is central, but it also has a lot of other things like headache, pain, abdomen, cognitive dysfunction. So this is what I want you to remember. So all of these symptoms are that of fibromyalgia, and all of them, as we can rightly understand, has so many differentials to each of them. So that brings the problem. But this just tells you how much our understanding of fibromyalgia has evolved from just being some tender points to where we see the disease currently. Classically, these are the patients who have chronic widespread pain. I told you widespread, both above and below the diaphragm and on either side of the body. midline. They have pain, and they do not have generally other systemic conditions according for pain. They do not have raised inflammatory markers. There's nothing on examination neurologically or rheumatologically. They have excess tenderness in soft tissues. So someone with arthritis, for example, if you just palpate at the joints, they might be having pain. But if they have pain even when pressing in between the joints, they will, if they have the pain, then it's more likely to be associated with, a pain in the muscle tissue, myofascial triggers. These are called myofascial triggers. These are very classical of fibromyalgia. And then they characteristically say that I hurt all over. I feel like I just developed flu, fatigue, IBS, irritable syndrome, multiple somatic complaints, and definitely exclude other causes. This is how I also approach this patient. I do not order a battery of tests, say ANA profile, anchor profile routinely, but I definitely make sure that I get my basics right. Always CBC, LFT, create thyroid, and sugars, calcium, phosphate. This much I definitely do for all my patients with suspected fibromyalgia. And then only I look at, based on the needs, what other symptoms are required, because all of these endocrine, metabolic, liver dysfunction can have most of the symptoms that I was discussing. And differential diagnosis, as we can understand, are plenty. It could be an endocrine cause, it could be an inflammatory cause, polymyalgia rheumatica in elderly particularly. One more thing, fibromyalgia first time starting in someone who's 70, 80 years is very unusual. Can happen, but unusual. Typically a disease of the young to middle age. So if you have fibromyalgia 70 to 80, always think of malignancy and polymyalgia rheumatica um, or paraprotein disorders first. And based on clinical features, the differentials also vary. So why fibromyalgia occurs? So is it that the patients are feeling pain in their foot? One thing I can assure you, these are not the patients who are faking their pain. These are not people who have somatoform disorders, so they are faking pain for any gains. Or these are the patients where the pain experience is absolutely real. So my teach mentor taught me, when the patient says they have pain, always think, always believe them. Never discard them. Just because you are not able to elicit one swollen joint doesn't mean that patient is faking. He's absolutely trouble and he is experiencing pain. So what happens in these patients is there is an abnormal pain sensitivity. So we know that all this is a classical diagram that I draw and explain to my patients also. So suppose there is nerve which carries impulses, pain sensation from periphery into the thalamus. That's where the entry point is for the most all the efferent sensations. So what happens is there is an abnormal pain sensitivity. So they have increased perception of this pain. Their pain fibers, which are located peripherally, they conduct more, they recept more to non-painful stimuli. And when they come into the central spinal cord, they also have increased transmission through the nerves. So they feel more pain because the central inhibition of this pain is lost. So they have abnormal pain sensitivity. They have small fiber neuropathy. Typically, nerve conduction studies are unable to show anything. And they have non-restorative slope. I told about sleep disturbance being one of the major problems. So sometimes in my patients, even simple melatonin or simple zolpidem helps a lot in overcoming fatigue, because if they put the patients to good sleep, they themselves will have good scope, and then they have always in a constant flight fight response. So our bodies tune in a way that our adrenergic system is triggered only when a tiger chases you. I mean, you are exposed to any danger. Imagine that these are the patients. I sometimes feel very bad for them. It's like they are exposed to a tiger. So it's at all the times in their life. So that is how their body responds, and that is why they are so tired. Now, why that happens, to put a little bit more complexity, I told about pre-existing factors. There are some polymorphisms in this, basically chemicals receptors like serotonin transmitters or endorphin receptors or even adrenaline receptors. And then they have precipitating factors. It could be micro trauma, deconditioning, sleep disturbances. It could even be a childhood trauma. What happens is they are highly perceptive to painful stimuli. So they receive more stimuli, the nerve fibers. And from there, when it comes to the central aqueductal matter, there is a gatekeeping mechanism that generally says that only above this threshold, we will allow the pain to go through. But what happens is in fibromyalgia patient, that threshold itself is lowered. So that's why, this because the descending inhibitory pathways are lost, you have excess nerve conduction and excess conduction into the a part of the brain that which is called insular cortex, which deals with this flight fight response in them. So what happens in these patients is generally they have stresses, cognitive dysfunction, psychological comorbidities. So they have a hyper responsive neurological system, any ongoing peripheral factors. So it doesn't mean that fibromyalgia should not have anything. I have a lot of patients with rheumatoid where fibromyalgia or pain sensitivity component is very prominent, where I'm not finding any inflammation, neither the labs are revealing, but the patients are in constant pain. So what happens is in a rheumatoid arthritis joint or osteoarthritis joint also, the initial trigger, which our body always knows to ignore. Say, if I'm sitting on the chair today and presenting this, my body knows that I'm sitting on a chair, but it tends to forget that information because it is not relevant, it is not harmful. It is this pressure receptor in my gluteal area are stimulating the nervous system, but they're below a threshold. So that is not allowed to be carried to my brain. That information itself is not carried. But what happens in patients with suppose this itself, this threshold is breached. Suppose if there is a pin lying on my chair, and if I strip any sharp object, it pricks me, hurts me, then it crosses that threshold and that information is carried, which is normal. But what happens in fibromyalgia is this itself is this so my threshold is
Screen is not visible again.
okay, sorry, now it's visible to me.
Yeah, now
Sure.
it's there.
Okay. So sorry. And this threshold itself is a problem. I mean, it becomes hyper responsive. So these non-painful stimuli, for example, sitting on a chair, because of the increased threshold, becomes responsive in fibromyalgia, and that continuous inflow tires out your brain. That is why the patients experience this fatigue. There is CNS hyper-responsiveness dysregulation, which is mediated by all these transmitters. So you have increased glutamate, substance P, and nerve growth factor, and decreased GABA nergic transmission and noradrenaline, which suppress this nerve transmission. So that is why we use pregabalin or gabapentin, because these are GABAergic drugs. They're also used in anti-seizure medicines. We well know them as anti-seizure. So they basically calm down the neurological system by reducing the glutamate transmission and increasing the GABAergic transmission. Whereas the same things are also useful for fibromyalgia. And that is why your duloxetine, which increases, noradrenergic transmission or synergic transmission, increasing drugs like amitriptyline are quite useful in fibromyalgia. So to integrate the model, so whatever I spoke, we can say that what happens in fibromyalgia is increased threat perception of the body and decreased soothing mechanism. So both are defective. So your nervous system becomes highly responsive, and also the soothing mechanism, the central control mechanism, which is supposed to reduce your sensitivity of your neurological system, becomes defective. And that is why you have increased transmission from your neurological system into the brain. So when it goes into the brain, it goes into the part of the brain which is called as dorsal prefrontal cortex, which lies somewhere here in the brain. And that is where your flight, fight, emotional responses come into picture. So there, this not very well defined anatomically, but we know that there is central executive network, salience network, and default mode network. So executive network becomes hyperactive. The salience network, which is supposed to silence the non-painful stimuli, becomes defective, and that's why you experience more tone. So that is why you see this with overlap with multiple conditions. So that is why, I mean, all this tension type headache, migraine, TMJ, joint, multiple chemical sensitivity, all of these are associated with fibromyalgia. And basically, they are called as central sensitization syndrome or central sensitivity syndrome. And that's what I, label my patients also generally. I tell them that you have central sensitivity. If you tell that you have fibromyalgia, it's all in your head, you have mental, it's going to make them feel even worse. There are many people who come to me, many of these patients come to me, just, I don't even take the drugs, give the drugs to them because these another patient problem is they are very hypersensitive to drugs. So gabapentin 100 mg, they start feeling drowsy. But they come and meet me and just talk to me for 5 to 10 minutes, and they tell me that you are the first person who told me that my pain is real. Otherwise, all the time I kept hearing my pain is in my head. So they just came. That relaxes their mind. They understand what is happening with them, and there are multiple non-pharmacological modes also. I'll talk about them, and they try to deal with them. So evaluation generally should be kept to minimal. As I mentioned earlier, I generally run liver kidney functions, CBC, thyroid functions, HbA1c, and calcium phosphate. Other tests like immunological tests, particularly, I'm not too keen on ordering in these patients, particularly if I don't have any definite inflammation, inflammatory markers are normal, and there's nothing wrong in the CBC, urine routine, liver function, kidney function. I generally do not order ANA, because what happens is if you order an ANA and it comes as 1+ positive, which when I was a resident, I used to report, I straight away used to give ANA 1+ as negative ANA. I don't even used to bother reporting them because it's so much subjective. And if you go reporting ANA by 1:40, 40% of normal people will be positive for this. So I tend to keep investigations minimal in those who have fibromyalgia, if I feel fibromyalgia. When I say, why I say that the fibromyalgia is there, because these are the patients who have 3 to 5 years of disease, pain symptoms all over the disease. They typically have depression, some childhood trauma. I rule out only pure major depression. Pain is the predominant control. They hurt all over on either side of the body, both below and above the diaphragm. And multiple tests and over a period of time, including liver, kidney functions, have been normal. So these are the patients where and on physical examination, very important, I'm not finding anything. These are the patients where I feel that the central sensitivity of fibromyalgia is the main component. So in these patients, I tend to avoid ordering too many investigations, because if one NA 1+ positive, then again that keeps lingering in their mind. They will then go for an NA profile. Again, some row 52 will come positive 1+, and this will just lead to unending, battery of tests and exposure to potentially harmful medicine. See, disease modifying agents, be methotrexate, hydroxychloroquine, steroids, they're all very good for those patients who need it. Rheumatoid arthritis, SLE, yes. But if you use the same things when pain all over the body, fibromyalgia, they are definitely harmful. So this golden rule we need to remember. Arthritis medicines are only good for patients with arthritis. Without arthritis, if you use them, then they are actively harmful. So we should try to not do harm to this patient. That also is an important Hippocratic oath that we need to remember when we are managing. I talked about extensively about the pathophysiology, because only when you extend, the pathophysiology, you try to address them. We talked about pain, so we can cut down that pain. I told you we can cut down this glutamate transmission by using GABAergic drugs, or I can use tricyclic antidepressants or duloxetine and cut down the pain. But that's just one part of this. They also have non-restorative sleep. You try to address that. They have vicious circle set in where the muscle becomes weak, and that further because of inactivity, and you try to improve their activity step by step, make them understand their disease so that they are less distressed. It cuts down many of these neurotransmitters by itself. And cognitive behavioral therapy, this is something which is extremely useful, particularly in my practice. So a good psychologist will go a long way in treating these patients. So typically for non-pharmacological treatments, for me, it contributes at least 50 to 60% in managing fibromyalgia rather than just treatment. So they are far more important than pharmacological therapy. And this has been shown across trials where they have a greater effect size than pharmacological therapy when used in right manner. So first thing, clear understanding of what the patient has. Explain them in their very simple language that you have nerves which are hypersensitive. Yeah, that's why they transmit more. That's why you are fatigued all the time, because your nervous system is hyper responsiveness to all the stimuli that are going on. And then gradual exercises. So these are the patients where you cannot ask them to do a deadlift of 100 kgs in one day or run for 4 kilometers on first day. They will give up. So I tell them every week or so, there should be a meaningful, increase in activity. So these are the patients who typically find it very hard to walk even 500 meters on a level ground. That's the problem. I mean, it's very easy to sit and advise you should walk 10,000 steps a day. You should achieve 70% of your maximal heart rate and do that 30 minutes a day for 5 days a week. And I understand this is all coming from good intentions to prevent metabolic disease, but this is not the exercise regimen that will work with fibromyalgia most careful. You have to be very gradual. I would tell them, you walk for 10 minutes every day. Start with 10 minutes and gradually increase. After a week, I want you to see at 15 minutes. I want only meaningful, small increments, whatever may be your pace. That's important. Start low and go slow. And all forms of exercise are effect. Aerobic studies are best studied, but even muscle strengthening exercises are highly effective. So in my practice, at least, when you build muscles, all autoimmune disorders as well as fibromyalgia responds very well. So this is something which I encourage highly for my patients. So a good physiotherapist also who knows how to deal with stamens. Once again, when they do a cycling or when they do a walk, they will have this myofascial trigger points where there will be a severe pain. So if you teach how to how the muscles are oriented, and you teach them methods to release them, and take a good physiotherapist help, it can be a very fruitful endeavor. In fact, to me, in my personal experience, 1/3 exercises help in dealing with fibromyalgia. 1/3 help is determined by a good psychology care, and only 1/3 is medicines. So this is something which I firmly believe in. The percentage varies from individual to individual, but this is what I believe is important for fibromyalgia. So one important aspect is cognitive behavioral therapy. Obviously, in this one small session, I will not be able to tell you how it is done. Neither I do it myself. I take the help of my psychology colleagues. But what basically happens in fibromyalgia, their cognition is impaired. So they have maladaptive thoughts. So the maladaptive thoughts, someone might have said, there is small disc pulse. So if you move, your nerve will compress. So that one small word by anybody loosely used. So if you do an MRI spine, you will have this spondylosis in 90 to 95% of the MRIs. But that small word, your disc is impinging on your nerve. So what it will keep in mind, it will edge in the mind of patients is my nerve is getting compressed by disc. If I move slightly also, if I even show a slight bend, that nerve will get compressed and I will go into paralysis. So these are the kind of maladaptive thoughts that the patients carry that will lead into maladaptive behavior. So he will completely stop walking, exercising, And as we know, this is a vicious circle that further weakens his muscles, that further worsens the spondylosis problem. And we all know that fibromyalgia, any kind of trigger is amplified 10 times. So that produces more pain, more maladaptive behavior. So this kind of vicious circle gets set in. So pain leads to inactivity, and inactivity leads to muscle loss, and then muscle loss leads to more pain. So this vicious circle has to be broken, and this has to be challenged, replaced with more realistic thoughts. One, I need to sit with them and explain what fibromyalgia is and why that small disc herniating in your back is not such a big deal. And then behavioral. Only when you alter the cognition, then you're going to use the adaptive behavior. You're going to try to increase the adaptive way. Sleep hygiene, graded exercises. For example, sleep is highly disturbed, so they should not take any caffeine after 6 p.m. They should not go near their bed till the time of sleep. The lighting should be beautiful. Every single thing is helpful to fibromyalgia. Then there are various complementary therapies like Tai Chi, yoga, trigger joint injections, myofascial release, acupuncture, meditation. All of them have myriad of papers helping these patients. So this is something, whatever. There are different set of patients where each of them work. I do believe that all of them have some role in managing fibromyalgia. And this is because of, so remember, whenever you're treating fibromyalgia, always remember this thing. You're trying to facilitate, there is an increased pain reception and a reduced soothing or inhibition of the pain. So that is where your medicines are going to be targeting also. So basically, you use amitriptyline. Typically, my first choice is amitriptyline or cyclobenzaprine, which blocks 5-deoxytryptamine and noradrenaline reuptake, increases these neuromediators, which reduces the nerve sensitivity. You can also use, in a patient who has depression as the major symptom, you can use duloxetine, milnacipran, or fluoxetine, paroxetine, zolpidem, zopiclone in select group of patients where sleep is highly disturbed. Then pregabalin, gabapentin, I make use of a lot of these patients, particularly at low doses. One important thing, start very low, maybe 25 to 50 mg. You cannot start pregabalin. You cannot start these patients on 150 pregabalin like you treat the patients of herpetic neuralgia or others. They will never take these drugs. Even 25, 50, they are highly perceptive to any kind of drugs and side effects of the drug. So start very slow and build up gradually. And some low-dose naltrexone, nabilone. See, these are not been regulatory approvals. These are cannabinoids because there is a dysfunction of nerve processing, so it can suppress the nerve function by use of this drug. Typically, I'm not used much of this, but this is something which is quoted in the literature, and some of my colleagues have used and found good results with it in a section of patients. Then you have tramadol. It's much has addictive potential, so I generally tend to use less of this. Anti-inflammatory drugs I use to acute control of pain sometimes. Then there's magnesium glycinate. So many of the magnesium supplements have some role. I typically put them on once a day. One interesting thing, there are papers which says that iron supplementation helps. So I typically 1 or 2 iron supplements I use, even if their iron hemoglobin is normal, particularly if the serum ions are low, less than 50 microgram per deciliter. I tend to put them on iron supplements. Melatonin I use a lot in my patient. NMDA antagonists like memantine, pramipexole, these are all reported in literature. I have not used much of them. So these are the different treatment options. I tend to typically use more of pregabalin, gabapentin. So to summarize what I have spoken together so far, fibromyalgia, think of that as a central sensitization syndrome and not as all in your brain kind of problem where you feel that patients are faking the pain. First, you yourself as a doctor need to be convinced the pain experienced by patient is absolutely real. These are the people who typically have widespread pain, typically lasting for several months to years. So someone with just 5 days of pain, I never label them as fibromyalgia. In fact, I never label anybody as fibromyalgia in first 6 months of my follow-up. So I call them as likely FMS, or I call them as central sensitization syndrome by all other means. But definite label of fibromyalgia, I'm very hesitant to put until a good months of follow-up I have made, and there's no other thing. It's not uncommon at all. See, there are particularly the field I work in. It's not uncommon that a patient with multiple and multiple enthesopathic all over the body, and you find that um, uh, they are mimicking fibromyalgia. So spondyloarthritis can mimic fibromyalgia. It can cause inflammation wherever muscles and bones, tendons attach into the bone. So multi-enthesial pains also can mimic fibromyalgia. So I keep the diagnosis open-ended, but these are typically the patients who have widespread pains more than 3 to 4 months. They have multiple other somatic complaints, temporomandibular joints, abdominal pain, heartbeat raising, palpitations, or urinary symptoms. And I'm talking about the typical patients, and they have done extensive evaluation. Nothing has been found on their evaluation. On physical examination, you don't appreciate anything. Routine tests like CBC, LFT, create, thyroid functions, calcium phosphate are all negative. Avoid ANA, RF, and this indicated this. I agree with this treatment from Hodgwork. And once you diagnose as fibromyalgia, then make the patients understand, use whatever communication methods you want to use, and take them into confidence. Tell them about importance of exercises, mind relaxation, good sleep hygiene, and then only switch to pharmacological therapies like low dose amitriptyline, duloxetine, gabapentin, pregabalin, and then you are likely to find good 60 to 70% relief in many of these patients. 100% cure, generally it's not very easily achievable. There may be periods where you are off drugs, but occasional pains often come and on. But the patients also realize, once they realize the mechanism of pain, they get reassured that nothing bad is happening inside of me. Then they also accept this pain, and then also psychological help. If you can alter their thought processes through cognitive behavioral therapy, you're likely to find good relief. So pain take-home points are pain experienced by fibromyalgia is real. It is generally widespread, not localized. So one low back pain is generally not fibromyalgia. Don't label a low back pain as fibromyalgia. Maybe myofascial pain syndrome. It's slightly different. Can coexist with other cancer, autoimmune rheumatic diseases associated with fatigue, non-reflection, sleep. Most lab evaluations are normal. So treatment includes exercise, CBT, patient education, and then come to pharmacological therapy. With that, I conclude. So I'll stop my presentation, and any questions I'll be happy to answer. Thank you.
Thank you very much, Dr. Abhishek. You gave us a very clear picture of fibromyalgia and how to consider pain real. We also see in practice how many of them are labeled as psychological problems and even treated by very strong antidepressants. This practice we definitely need to take an opinion from a rheumatologist before labeling them. And as of now, I don't see any questions on the chat box, but I have one or two questions for you. So my first question is, how long and how safely you can keep giving gabapentin and pregabalin? Because it tends to be very chronic, the pain. And how long can you give it? Can you give it in break the cycle, then again give it again? So a little more light on that.
Excellent question, ma'am. Generally, these are medicines which are very safe. Unless there is underlying renal dysfunctions or hepatic dysfunctions. Even in them, the low dose of pregabalin, gabapentin can be used. But unless in these patients, and when we are using at much lower doses, say less than 300 mg of gabapentin or pregabalin about 75 to 150 mg per day, I have not seen cognitive decline with these patients. So they can be given for years together. I have patients who are on these medicines for decades together. The only thing that I am, as a practitioner, you are worried about is um, whether it causes cognitive decline or other things. Generally, it doesn't. At low doses, I have not found much response. But after a long-term treatment, withdrawal has to be really gradual. So, patients can end to develop dependency. So, if you're treating 300 BD gabapentin and stop, suddenly withdrawal can be very severe. So, you have to be very careful. Patients sometimes may have even seizures kind of or pseudo seizure kind of activity. So, withdrawal has to be gradual when you're treating. Otherwise, these medicines can be safely used. And once in 6 months, I just monitor routine things, but even that is not very well described in literature that you need to monitor. But I tend to monitor like routine liver, kidney functions, and CBC and things. And there's no clear answer. I mean, whether you can stop the drugs. Yeah, obviously, we always should try to keep every medicine as low as possible and as short as possible. So if you're under control, you try to reduce these medicines and make it alternate day and try to stop and see. Sometimes there are good intervals for, when I say decades together, there are intervals in my patients also, where fibromyalgia, where they're off medicines for a few months, and then you can put them back if the symptoms recur. I'm not able to hear, ma'am. Sorry. Yeah.
No, I'm just unmuted. My second question is, the scenario may be like this: patient with a typical RA is complicated. They can both coexist? You did speak about coexisting with cancer and other uh, conditions, but they can coexist with RA or some other condition. How do we manage or how do we approach such patients?
Ma'am, this is typically we think of whenever a patient with chronic arthritis, when you know that his joint disease is controlled, when your typical physical examination aided by, if required, lab investigations, inflammatory markers, and imaging, all are not showing any active inflammation, but still the patient has severe pain. And pain is not limited to joint region. See, typically, if rheumatoid should be only at the elbow, wrist, and nothing in between. But if the patient has pain, yeah. So this is one of the things I also use to, explain the patients what is happening. So I press on the patients. They're typically very receptive to any kind of stimulus. So they experience pain. If the relative is standing next to them, I just press on them with the equal pressure and show them, see, he's not feeling pain. You are feeling pain. So that indicates that there is a sensitivity. There's a nerve sensitization which has developed, which we need to break, which could be through cognitive behavioral therapy, exercises, proper conditioning, eating good food, good sleep hygiene. All of this will be required. It cannot be only medicines. And then low dose of amitriptyline or other medicines I add on to my rheumatoid medicines. But what I notice is sometimes what I commonly see, a patient with rheumatoid, otherwise very well controlled, but because of the pain, you keep on jacking up the medication. So from methotrexate to methotrexate and biologicals, you keep on jacking up the medication. But when the underlying mechanism is not inflammatory, these are unlikely to happen. So you optimize your disease modifying these drugs. Obviously, that's the first priority. But also look at this component, because this is in fact, the latest EULAR guidelines speak about this, that EULAR article speaks about this, about non-inflammatory persistent rheumatoid arthritis. So these are the patients where they do not have inflammation as the feature. And this is something where physical examination helps. I mean, there's no one thing which can help really. I can't say that CRP is negative, so it's non-inflammatory. But a combination of physical examination, lab investigations, and imaging help you as a treating clinician to deduce whether your disease activity is able to explain patient's pain. If it is not, think of central sensitization. And generally, these are safe medicines. One way of looking at it is just start them on 10 mg amitriptyline, 50 mg pregabalin, or 100 mg gabapentin, and see how they react. If the pain improves, that's one good way. So that's one of the things that I also do. I mean, the patients comes with fibromyalgia, like even before putting the patients on medications, like before doing the test, I mean, CBC, LFT, all this takes 2-3 days, or any immunological marker. So I then put them on pregabalin and gabapentin and see how they respond. So this is the approach that I use. If they respond 20-30% very fast to this drug, then there is a central sensitization component. And unlike methotrexate or hydroxychloroquine or any other rheumatological drugs, I don't need liver kidney functions to start these drugs. So I start them, see how you respond, and then take a call.
Any role of steroids?
No, ma'am.
On the chat box.
No, that's something which has to be avoided at all cost in these patients for sure. And there is a talk about neuroinflammation. There are a few articles which talk about this neuroinflammation in these disorders. But definitely at the current level of evidence, steroids are going to be only counterproductive in this group of patients. And they are not going to improve. And it's likely to cause sarcopenia, that is muscle loss, and further aggravate the condition.
So there was only one question on the chat box, and people have started thanking. On behalf of FFPAI, the president, Dr. Pragnesh Shah, and Dr. Pragnesh Vacharajani, the honorary secretary, myself, Dr. Priti, thank you immensely from the bottom of my heart for accepting this invitation. You have given us 4 talks, 4 sessions, and covered almost all the topics of rheumatology. And thank you very much, Dr. Abhishek, for accepting and giving us this insight. There have been many appreciative comments in the groups. I mean, no words to tell you that each of them to convey to you, but thanks from the bottom of all our hearts. It was really insightful, and a lot of our doubts have got cleared.
So kind of you. Thank you. And thank a lot for FFPI for providing me this opportunity to speak on. This is something which most of the things that I spoke is something which comes from practice of what I do.
Yeah.
And at any time, anything, all of you are welcome to ask me anything. And I'll try to help in the maximum way that I can. And I hope that it will be somewhere useful. These are some very basic topics of rheumatology, which I feel are important for even a family, for even a first primary care physician.
Thank you, sir. And thank you, viewers. And before I wind up, once more the announcement. After I was just waiting to conclude this session to avoid some confusion. So now I will be posting the link for the certificate course in all the groups. So kindly all of you register. We will be starting on 13th November, which is on the World Diabetes Day. And we have eminent faculties from all over India who will be taking these sessions, and you will be provided a certificate at the end of the course. All your attendance will be monitored back end, and only when you complete the criteria, you will get your certificate. So kindly register in large numbers and let us take it forward and make it free. And we will come out with similar certificate courses in future too. Thank you all. On behalf of FFPA, thank you, Rahul and Enlace Code for the session. Thank you for the back-end help. Thank you, sir. Thank you, all the viewers.
I'll take you. Thank you, ma'am.
Thanks. Rahul, you can end the session.